Really, I hope you all enjoyed this morning, complex TAVRs, basically in pelvic valve, biophoretic ruptures by David Cohen. Really, thank you for coming, joining us, and pelvic valve for core valve, paravalvular leakage. And you really enjoyed the last cases, porcine prosthetic with a cautious reach. We successfully deployed a core valve. And so these cases would be the last ones from the AMC and in our TCS conference. And so actually Duk-Woo, Cheoran Lee, as our family, and some many collaborating physicians, and so we'll do discuss last cases. So Duk-Woo will
Okay,
discuss
hello.
this one.
Yes, this case is the last case. The last case is also the clinically complex case. 77 years old woman and admitted with neoclass 3, 4 dyspnea, and she has a history of hypertension and also the end-stage renal disease on hemodialysis is for 3 times per week. And also the echocardiography shows low flow and low gradient severe AS. And at history, and she underwent a stent due to AMI 7 years ago. And the next. And then looking at hypertension and ESRD, the STS score 12.21 is the high risk. Literally, it's a high risk the STS score. And next. And the ejection fraction is also very low, 23, and the ischemic insult of added territory. And the initial, the Vmax was 3.6, and so we do dopamine, the stress echo is Vmax increased up to 4.3. That means a low flow, low gradient severe AS. And at first time, 3 months ago, there was a 2 centimeter elbow thrombus. So at that time, we started warfarin, and definitely disappeared. Patient was admitted 5 days ago, and we changed the intravenous heparin. And a couple of hours ago, we stopped the heparin. It's now yesterday we checked also transthoracic echo. There was no elbow thrombus. And the next, okay, next. So the next. Looking at the peripheral artery is okay, and there is some bending, but there is no severe calcium, 7.3, 7.9. Next. This is short diameter is 19.2, long diameter is 24.3. The anatomy is not hostile. Okay, next. This is a sinus of Valsalva area is okay, and the ST junction is okay. There is no severe calcium. And next. And the alveoli, there was no severe alveolar calcium. This area is okay. Next. So this is an annular view, and the calcium score is just small. It's a 94. There was no severe calcium. Next. So coronary height is okay. Left is 11.4, and the right is 11.9. Next. So, and our algorithm CT-based charting, and we select SAPIEN 3, and the 23 is oversizing is up to 14%. So, and we already put the wire, and this is the Safari wire, and then we are the direct stent with the SAPIEN 3 23.
Okay.
Okay.
So these cases, anyway, the low ejection fraction, so relatively, high risk patient. So we did direct S3 implantation. The reason why, as mentioned before, the calcium score itself is okay. You're gonna do that. Calcium score itself is very low, 94 cubic millimeters, and so we're gonna do direct. Okay.
I always put a little bit more cranial to make sure that your dot is flushed with the edge of the S3, because S3 has to be within a millimeter, so make sure that you can see the tangentially across that end of that
APV로
S3
한번 딱
valve.
맞춰볼까?
Okay.
Okay, get it?
And the wire is
Routinely-
slightly pulled back.
Yeah. Okay.
Yeah,
Wire.
so because it can be off a little bit.
Okay, got it.
Good.
Okay, good.
Perfect.
자, 우리 저 에피코럴 뷰로 맞춰보고.
Okay.
Okay, just a
routine angle.
So this is a
Okay, go ahead.
23. Sorry, Duk-Woo,
23.
this
yeah,
is a
right.
20
This is 23.
So by charting, is it the area between 23 and 26? It's 360. Is that right?
No, it's between, it's
It's
under
three.
for 23. It was,
Under 23,
they
right?
made the
Okay, got it.
Okay, quite easy.
Diameter is
to
pretty
Is the
cross.
pass.
And
Then
Must be not
Device
been on
on.
renal dialysis for
Okay,
too
right,
long. There's
right.
very little calcium.
Okay, got it.
Yeah,
okay,
it's
yeah.
odd.
Because usually years of
자, 코플
dialysis
안으로
will
맞추고
calcify
줌하고.
everything.
Test. Okay.
Okay, good.
Good
It's slightly pull back.
position.
1 millimeter further.
Okay,
This is 23.
okay, test. Okay, got it.
1 millimeter.
We just leave the picture.
0.5 millimeters further.
Okay. Okay.
0.5 millimeters.
Ready.
Test.
Just
Just
a little
a
further.
little further.
Okay, good.
Okay.
Okay,
Test
right now.
one more.
So we want the big dot of the S3 just above
Okay,
the
ready?
lowest point of the three
됐죠?
sinus. So it's ready
Okay.
to go.
Pacing. Contrast. Okay. Inflate.
Inflate.
1, 2, 3, 4, 5. Deplete.
And
Okay.
pull the
Pacing off.
system out.
Okay.
So David, do you do fast inflation or do you
No,
slow
we,
inflation?
so we do a much
자,
slower
혈압
inflation
보고.
and we leave the pigtail
Okay.
down.
All right.
We never predilate.
Wait for a while.
Okay. The blood pressure
It looks good, but
goes up.
Yeah, the LV is a bit weakened, so obviously that
조금만 더
the
떼고
pressure may come back a little
but I
bit
think
slow.
but we
Okay,
probably
좀
deploy the valve 3 times slower.
Okay. Enjoy.
Yeah, we
Ready?
typically still, because you can adjust a little bit if there's a movement.
Full
Yeah.
shot.
So when you do that fast, there's no chance to react to it.
There's some.
A lot
All
of AI
right,
there.
Weak.
we're gonna check the transthoracic echo.
Yes. Can you check the transthoracic echo?
See the wires really. Okay. Would you show that?
Yeah. Yeah, the valve position looks pretty good, so
Yeah.
I wonder if it's central.
This is a safari wire?
Yeah, this is safari wire.
Yeah.
So this patient is now
We
doing.
typically use a much softer wire just so that it doesn't
Extra stiff,
push on. Yeah, extra stiff, so it doesn't push on the leaflet and give you the sort of aortogram that you worry, but it's actually nothing.
Okay, Dr.
think it's all
Ho, can
central.
you explain echo finding?
So on the parasternal long axis view, I can see only central AR,
It's all central air, yeah.
and on the short axis view, there's
It's a lot of central air.
most of it is central.
Mainly central,
mainly
right?
central.
So I wanna repositioning wires like this. What do you think? Okay. All right.
Or just take a soft catheter, put a pigtail in.
All right. Do you want that?
Like, again, I think
Okay. Well, take a picture.
Okay, ready?
Okay.
한번 다시
the extra
해봅시다.
stiff is much better as a wire for,
Yeah.
for the S3.
Oh,
It's better.
yeah,
Much better?
Yes.
Yep.
And then so we're gonna
Make
make
it
hers almost, how can I say that? Add more.
Just
Pull out and wire out. Okay. So
But it's gone
make
now.
a-
Yeah, yes,
Make a more.
yes. Okay,
alright.
한번 쭉
Press
준비됐죠?
here.
Okay, and you're ready? Shoot. Yeah, just a mild AR.
Mild now.
Yeah,
I would say
right.
trace.
You're gonna
very
wait.
little.
Yes, we're gonna wait 5 minutes and
We're
then
gonna
we check
wait
the.
5 minutes.
Yeah, right. So, this patient is anatomically is benign, but this clinically is a very the high risk patient. The STS-4 is a 12, and we discuss the method is MAG or general anesthesia with the anesthesiologist doctor. Is that some anesthesiologist doctors recommend the MAG would be better. Some drug for general anesthesia much more harmful for low ejection fraction and ESRD patient. So now the patient is doing the MAG, and because of the overall anatomy was benign, the procedure itself is very simple. Yes.
So typical minimalist TAVR.
Yeah.
Not general anesthesia. So very simple procedure.
Yeah, right,
so
right.
it takes us just 10 minutes.
Yeah. Just
And in terms of AR, right, especially for S3
Yeah,
concerns,
yeah,
it
yeah.
will getting less in terms of.
You want to maybe check the transthoracic echo one more time?
can you check the transthoracic echo one more time?
Yes, there's
이분 됐을
only
때 한번 찍어보자.
trivial MR, AR on the RV side. But there is no significant AR.
And do you find slight recovery of LV function on echo?
From personal long axis view, it looks just as the same. The previously patient has ejection fraction of 32% on the LAD territory wall motion mostly. And it looks similar systolic function-wise.
So, Jung-Woo, what was the size? What is the percent oversize with the 23? You said it was.
It's a 15 offside. Can you show us the offsiding path again?
Yeah.
Okay, 14.
14.
Yeah.
Okay, we're gonna check
Take a picture
again.
again?
Yeah, this is the right corner of you, and you're ready? Full shot. Okay, just is the mild AR.
어떠세요?
I think that the
Picture
result
view,
is
right?
is okay. Yeah, acceptable.
Yep. And I think you're.
All
I think it's
right.
pretty reasonable.
I think it's good. I think
Yeah,
you know
right,
you just said.
Yeah, we would
No need
again.
to watch
I
it.
think
We would do more hemodynamics for these kind of cases.
so again. It seems like you guys don't like to do LV pressures very much. We do a lot of make a lot of decisions based on the hemodynamics plus the imaging. So.
We're based mainly on imaging. We don't want to look at aortogram because you're always going to see a little this and that type of thing. You don't know what to do with it because it all depends on pressure, depends on how much dye you inject, contrast.
Yeah, we do lousy
When you
aortograms.
inject 1,000 psi, you're going to get something for everybody.
Yeah, right.
So we don't really look at it. So SJ,
Okay.
are you going to watch more? Are you
No, no,
happy
no,
with
No,
the
no, no,
result?
we're gonna finish.
I think it's quite enough. So
Yeah.
we're gonna wait on electrogram again, and I believe the probability regurgitation is trivial or something. Okay. Anyway, this year's meeting, through this year's meetings, we've learned a lot from the more complex TAVR procedures, and hopefully next year's meeting, our AP valves will be held in Beijing, China. So we're gonna, co-organize with CIT in China, and so hopefully you can enjoy in another, place in Beijing. Make more, interesting cases from Korea and China too. And so, hopefully, see you again in next, Beijing AP Valves.
Thank you very much.
All right.
Thank you. Thank you very much.
Thank you for a great case.
Yes, thank you.